Prasad Kashyap. Birendra Prasad. BP, I knew BP Kashyap, Birendra Prasad. The sir is going to talk about demystifying CTRs. As you saw in this particular case, how to put a CTR, how to select CTRs, which are those cases, sizing, fixation, various things are there with CTR, and it is one device which should be there in your operating table most of the time, because back subluxation can occur any time during your procedure also, even in normal cases sometimes. The CTR, if there, it's always handy. Yes, sir.
Hi, good afternoon, everybody. So we all know that the CTRs are required in our operation theater. It is used for many indications like subluxations and the zonal weakness, and if you find the zonal weakness per operative and all those. So you can put the CTR immediately after the rexus, after the nuclear management, in between the nucleus management, before the IA, after IA, and probably many a times you put the CTR after IOL implantation. The phaco surgery, because it's a closed chamber, it has advantages and easier to put the CTR, and it is little more tougher in cases of SICS because the incision is large. So I'll be discussing about putting the CTR, because you have seen CTR being put, the leading haptic, everybody is showing that, okay, it's going to the bag. But the posterior rung, how it goes into the bag, that is very tricky. So you can put the CTR clockwise, you can put the CTR anti-clockwise, you can put the CTR only by forceps, that is the trailing ring, or you can take help of the forceps and the Sinskey hook. I'll be talking about the Sinskey hook and the forceps, and sometimes two Sinskey hooks. So you get the CTR, in many ways. You get a ring only. So you get a preloaded CTR. If they are preloaded, there are two types. Left side it opens left side, right side it opens the left and right side, and there are some which you load in the tube and then you inject. So those are kinds of CTR. So I'll be talking only about the ring only, the simple available ring without any preloaded or injectable. So can we have the sound, please? A case of subluxated cataract, CTR inserted clockwise, and the trailing ring of the CTR is pushed by the 25 gauge forceps in the bag. A mature cataract with high ILP, puncturex is done, capsular dehiscence was seen only after IA, CTR inserted clockwise, and forceps used to push in the bag but slipped. Sinskey hook used to engage the ring and pushed it in the bag. The trailing of CTR was pushed by the Sinskey hook, and the other Sinskey hook helped the body of the CTR to get aligned in the bag, and the simple pressure on the body releases the Sinskey hook from the ring, and the CTR goes in the back. In SICS, preferably CTR should be inserted through the side port. The trailing ring left in the AC, and the Sinskey hook picks up the ring of CTR and pushes it in the bag, and the tap on the ring releases the Sinskey hook from the ring. A case of cataract plus strab. After inserting the IOL, we found capsular dehiscence. CTR inserted through main incision. The forceps feed the ring to the Sinskey hook, and Sinskey hook guides the CTR in the bag, and the ring of the CTR is released from the Sinskey hook by a tap of the ring. takes it there and the
A
tap
case of coloboma of uval tissue with a capsular dehiscence suspect at the colobomatous area. In this case, the trailing CTR ring is inserted in the bag by the forceps only. And the surgery is completed after SFT, pupilloplasty. After the cataract removal, capsular dehiscence was found. CTR is inserted and the ring of CTR slipped and lost in AC. Sinski hook from side port fetches the ring and guides it to the capsular bag.
If you lose the ring behind the iris, you are in trouble.
Soft cataract with coloboma of iris. The capsule is stabilized by the hook and the CTR is inserted before the whole cataract was removed. CTR inserted by the help of forceps only. And the surgery is completed with SFT pupilloplasty. A case of capsular dehiscence more than 90 degree. The forceps pushes the ring and the hook from the side port, it guides the body of the CTR in the bag. And the CTR is checked by rotating for its position in the bag. So these were few tips I thought to give it to you. Thank you so much.
Any questions, sir?
Thank you, Dr. Kashyap, showing those difficult scenarios where CTR put in a different manner. Just one question to Dr. Satyamurthy. Do you use these, preloaded CTRs in your cases?
No, earlier I used to use this metallic injectors, CTR injectors, but because that visco used to get, so next cases I used to see a lot of visco coming out of the thing. So that's why now I used like what sir showed similarly.
Okay, simple
I have no
manual
idea.
devices.
Yes, sir.
Anybody uses injector system, preloaded CTR? Dr. Sunil?
I do use.
Okay. You find that comfortable, sir?
Yeah, it is. It's in certain situations, it's a lifesaver.
Yeah.
Sometimes it's of so much manipulation, you can just go ahead and inject it. And whenever you're doing it manually, you always support with the other hand, the CTR. Be very careful, otherwise you can lose it.
That is absolutely true. You have to make sure that your leading haptic is inside the bag, and that once you put it a little pressure towards the rexus margin, it should tent the rexus, so you know that your CTR is getting inside the rexus, inside the bag. Otherwise, it will go over the rexus and you'll not find it, and label it will go haywire. And once it goes in a sulcus area, very difficult to retrieve that. But
Dr.
make sure
Sunil,
it's in the bag.
Dr. Sunil, you put CTR in one case of PCR?
PCR, no, never.
Yeah, you should never put that. Yeah.
Never in
Okay.
PCR.
No.
So there was a video this time in APACRS where it was a best innovative video award to that person, where he devised the loading device where both the leading and the trailing eyelets could be injected inside the bag. So you don't have to really worry where this is going to open. That was fantastic video I've seen, innovation by somebody. Maybe it will come in market very soon, where you have both the eyelets inside. First it goes like this, then you can do the second hand, it goes inside. So those preloading devices can be sometimes better, especially in a large subluxation, shallow chamber, upthrust. Things can be managed very effectively. So we have seen so many videos. CTR is a must sometimes in your operating, not in table. It should be in your operating area. Suppose you have something, you can easily put CTR and manage the bag. Thank you, Dr. Kashyap.
I had to check for 3-4 years of my surgery so I could find so many CTR.